Welcome to what I hope you will find is a very informative webinar. We're going to be talking about the revised commissioning guidance for lymphedema services and how this can support better services for patients with lymphedema across London. My name is Jane Nicklin. I'm the facilitator for the London Lymphedema Community of Practice, and I'd like to introduce you to our speakers today. First of all, we have Dr. Christiana Gordon, who has worked in the field of lymphedema for many years and is the consultant in dermatology and lymphovascular medicine at St George's, London. And there, she and her team care for people with primary and secondary lymphedema from across the United Kingdom. She will be taking us through what lymphedema actually is and how it is diagnosed. Dr. Karen Robb and Mary Woods have been instrumental in developing the London Lymphedema Community of Practice and through this group revising the guidance. Karen Friert is the Chief Exec of Lymphedema Support Network, which provides advice and support to patients from across the country. She has a national role sitting on the National Lymphedema Partnership Group, and she also has a role in advising on the guidance document. Emma Tingley from Macmillan Cancer Support has been the sponsor of the Community of Practice and this work to revise the document. And finally, Liz Price from Transforming Cancer Services Team for London has been co-sponsoring the work. This group will also be talking on a panel discussion at the end, so please, if you have any questions as you go through the webinar, please put them into the chat box and we'll be collating them and using them in the discussion. Finally, please mute your microphones and take yourself off video while the webinar is processing, because we need to be able to see the speaker and their slides as we go through this. So without more ado, I'd like to hand over to Dr. Christiana Gordon. Thank you.
Lymphedema. What is it? Well, lymphedema is the swelling of any body site. In other words, it's the same as chronic edema, it's swelling. And why does it happen? Well, it happens when the lymphatic system can't drain fluid properly from our tissues. And that could be in the case of primary lymphedema, where children and young adults have a genetically determined weakness of their lymphatic system, or it could be as in the case of secondary lymphedema, where someone is born with a healthy lymphatic system, but something then damages it and it doesn't work properly. So who gets lymphedema? Well, it can affect newborns to the elderly. It does not discriminate. It is chronic and incurable, unfortunately, but it is treatable. So in the case of secondary lymphedema, there are many possible causes for damage to the lymphatic system and why somebody might get swelling. And here's a list, but it's not exhaustive. But the one that we're going to pay attention to today is malignancy-related lymphedema. And how common is lymphedema? We need to know that before we start, our discussions. Well, it affects more than 400,000 people in the UK, and I think that may be an underestimate, judging by the number of swollen legs I see when I go around the supermarket. And that number also reflects a combination of primary and secondary lymphedema, but a large number of that will be malignancy-related lymphedema. Lymphedema is as common as Alzheimer's disease, 4 times as common as HIV, and 12 times more common than multiple sclerosis. And if you think about the amount of education that we get on these diseases compared to the minimal education that we get about lymphedema, personally, I think it's scandalous. And if you think about the fact that 1 in 5 women with breast cancer will get lymphedema, it really does make us think that we have to do more about treating this condition. So, breast cancer-related lymphedema, you can see an example here in this lady. She underwent lumpectomy, lymph node clearance and radiotherapy to treat her breast cancer. And whilst she's been cured of the disease, unfortunately, she has a lifelong reminder of her cancer. That is, oh, sorry, we're just sharing someone else's slides there. Not sure how that happened. Perhaps we could go back to mine. Barbara, are you in control?
Sorry, I'm not.
Oh, someone else has started sharing their slides. I'm not sure. Okay. Let me see if I can go back to sharing mine. Sorry, everyone. Open share tray. Right, back in control, I hope. So we've got a case of breast cancer-related lymphedema here, and you can see the swelling that extends from this lady's arm up into the shoulder, and that is a chronic and uncomfortable condition for her. And how, why did she get it? Well, it's because of disruption to the lymphatic drainage pathways. Breast cancer itself can rarely present with lymphedema, but usually the lymphedema breast cancer is due to the treatments that the patient has had. So just having one lymph node, the sentinel lymph node biopsy in the armpit, carries a 5 to 10% risk of that woman developing a whole arm lymphedema. And if she then goes on and has axillary lymph node clearance, that risk increases to 20%. And if that patient also has radiotherapy, that further increases the risk of lymphedema to 40% or higher in some studies. And the lymphedema doesn't have to come on within a few months of having breast cancer treatment. There can be a delay of some years before the lymphedema develops. And it's not just breast cancer that is associated with lymphedema, other malignancies. For example, this patient had a melanoma of the lower leg, excised and grafted, and you can just see the scar of his inner thigh where he's had his inguinal lymph node dissection, and that carries a very high risk of developing lymphedema as a consequence. And you can see the significant swelling and probably a resolving cellulitis of the thigh. So why should we bother to treat lymphedema? Well, before we can answer that question, we need to think about the impact on the patient. We really want to improve their quality of life, but we also want to prevent complications for the patient and also the complications and burden on the NHS that will have. So before we come on to how we manage lymphedema, we need to understand the lymphatic system in a bit more detail. So what does it do? Well, the lymphatic system's first job is fluid homeostasis. It's vital for making sure we don't swell up like the Michelin Man. It drains the tissue from the interstitial spaces and recirculates it round into the blood system. But the lymph system is also vital for immune surveillance. Our immune system travels in our lymphatic system. So sluggish lymphatic drainage or lymphedema will lead to sluggish immune surveillance, and the patient's more at risk of infections. And recent research suggests that the lymphatic system is also vital in the regulation of inflammation and fat homeostasis. So if these are the functions of the lymphatic system, then these are the consequences of failure of the lymphatic system. Your patient will have lymphedema, so that's the swelling, and the subsequent elephantiasis skin changes, the papillomatosis and the thickened skin. They'll have more problems with infections, typically cellulitis, but it could be nasty athlete's foot and viral warts. There will be an increased risk of local malignant change, and that's because of the altered immune surveillance. So they're more likely to get skin cancer on that limb or the rare but deadly lymphangiosarcoma. And unfortunately, lymphedema will also promote fat deposition, and I'll show you a few slides later as to the complications that can cause. But there's also problems with reduced mobility with a big heavy limb. In lower limb lymphedema and infections, there are often issues with leg ulcers and chronic wounds. The patient will often have a reduced quality of life, and that can lead to mental health problems, depression, and other issues as well that will need addressing. So if I just show you some clinical examples of the consequences of lymphatic failure, well, the first one is lymphedema, and that can be mild, but it can be severe, such as in this case here. And unfortunately for this young lady who's only in her 30s, the failure of the local clinicians to refer for treatment early on led to the development of life-changing disabilities from her lymphedema and recurrent sepsis. And we couldn't manage her as an outpatient and had to bring her in for treatment a couple of years ago, and the cost to the NHS was over £100,000, not to mention the impact it had on this young lady's life and the fact that she was away from her family for many months. Other consequences of lymphatic failure include this. This is a nasty cellulitis that you can't manage in the community with oral antibiotics. This patient will need to be admitted for intravenous antibiotics, will probably have a prolonged hospital stay. The leg will break down. There'll be messy wounds, ulcers that need to be cared for in the community. And so the cost of cellulitis to the NHS, as we all know, is significant, but the figures when you see them are quite striking. Cellulitis causes 400,000 bed days a year in the UK, costing more than £250 million a year. Cost savings can be made by treating the lymphedema that's present in many cases. If you look for it in a patient with recurrent cellulitis, there will be lymphedema. And this has been supported by the introduction of a London lymphedema service a few years ago, where they set up a lymphedema clinic. And after a year of their input, this was associated with a 94% decrease in cellulitis incidence and an 87% reduction in hospital admissions that year for their cohort of 500 patients. And so it proves that early introduction of lymphedema treatment will reduce the risk of infection, which is great for the patient, but also great for the burden on the NHS. So lastly, another consequence of lymphatic failure is this lymphedema can turn fatty if untreated. And here's a post-mortem example here of the patient's two arms. On the left, you can see their normal arm with a bit of fat, but on the right side of the screen, you can see a grossly swollen arm, and that's increased fat deposition there. And that's happened because of the chronic lymphedema that wasn't treated. And unfortunately, the only way to manage lymphedema when it's got to this fatty stage is to have liposuction. And that is the only nice approved treatment at the moment for lymphedema. But it's costly. It's not a cure for the lymphedema because the procedure itself will cause more lymphatic vessel damage. And so the patients afterwards have to wear really strong compression garments 24 hours a day for life to prevent worsening of the fluid swelling. And again, early introduction of lymphedema treatment with compression to treat the fluid component of swelling will prevent this abnormal fat deposition and the need for costly surgery. So you're asking now, well, how do we treat lymphedema if we want to do it well? Well, management starts off with prevention of infection through good skin care. And if they're having recurrent infections, then you can use prophylactic antibiotics as per the guidelines. And then the principle of compression treatment is to get the most out of the remaining lymphatic drainage capacity. And so we use intensive bandaging if there's a very large arm or leg that needs to be reduced dramatically in size before moving on to the maintenance phase of using compression garments worn every day to maintain that volume reduction. And we encourage the patients to exercise. It's vital they're in control of their weight. And in some cases, we will suggest the use of manual lymphatic drainage massage or perhaps surgery, but each case needs to be assessed by a lymphedema specialist. And care should be offered by a local lymphedema therapist-led service, but it's also important to recognise that these therapists should have access to a specialist tertiary clinic for their complex cases where they need support, such as advice on infection issues or surgery. And here's an example of a leg that's in desperate need of skin care with the hyperkeratosis, papillomatosis, and the lymphedema swelling. But in the hands of a good lymphedema therapist, within a few weeks of intensive treatment, dramatic results will be seen. They'll be using a combination of multi-layer lymphedema bandaging to reduce the volume, and then fitting the patient with compression garments here. You've got up to the knee compression socks, and you've also got toe caps on the feet to provide pressure, compression to the individual toes to maintain the results. And I just want to show you that treatment can work. Here's a gentleman with bilateral lower limb lymphedema, worse in his left leg because he had a DVT in that leg that complicated matters. And he attended lymphedema treatment every day, Monday to Friday, for 6 weeks for bandaging. No surgery took place, but this is the result after 6 weeks of treatment. A significant result, I hope you'll agree. And then he's fitted with special compression garments to maintain the results. And in this case, the benefits to treatment for him were a reduced swelling or limb volume, reduced incidence of cellulitis. He had improved mobility, which helped him continue with his weight loss efforts, improved quality of life scores, and a really visible benefit to his mental health. And whilst he wasn't aware of it, he also achieved a reduced risk of local malignant change within those swollen areas and a reduced risk of abnormal fat deposition. So just to summarise for you, my key messages are: lymphedema is a common but under-recognised condition that's often mismanaged in the community through no fault of the GP or the community nurses. It's just simply not on the radar at medical or nursing schools, and we need to address that. But cancer patients should have a clear treatment pathway, which includes early referral to a lymphedema service if they develop swelling, and unfortunately there's a fairly high chance that they will. Treating the lymphedema will reduce the risk of complications such as cellulitis, localised malignancy, fat deposition, mobility issues, and psychological issues. An inability to access lymphedema care will cause unnecessary suffering to the patient, with complications and preventable costs to the NHS. Thank you.
Many thanks, Christiana, for that quick run through. Amazing. In such a short space of time, you got so much in there. Thank you very much for that. Just 2 points from the beginning of the webinar. We are recording this, and you will be able to find it on the Healthy London Partnership website after the event. Just search for lymphedema under that website. So that's one thing to say. And secondly, I didn't say at the beginning, but if you have any questions, can you type them into the meeting chat on the right hand side of the screen? You'll see a little chat sign in your toolbar if you haven't got it up already. could you type in your questions, and then what we'll do, we'll collate them for the panel, which is going to take place at the end of the webinar, and try and address as many questions as we possibly can. Thank you very much for that. So without more ado, I'd like to introduce our next two speakers. We have Karen Robb, Dr. Karen Robb, who's been instrumental in getting this commissioning guidance written in the first instance and then revised. And she's been working in the second instance with the community of practice, and Mary Woods is one of the leading people within that group, and she's going to be joining Karen to talk about this work. Thank you both.
Thank you, Jane, and I'm just waiting for the slides to load. Liz, thank you.
They are coming, just bear with me.
No problem at all, no problem.
Wrong ones, hang on.
Just while we're waiting for the slides to load, I'm just going to ask Mary to introduce herself as well, because we're going to be doing a bit of a double act now. Mary, would you like to say hello?
Hello everybody, I'm Mary Woods. I'm nurse consultant in lymphedema at the Royal Marsden Hospital, and I've been involved with the community practice for the last couple of years, working with Karen and the rest of the group. Slides look like they're loaded now, Karen, so I'll hand back to you.
Thank you so much. So I'm currently working as the programme lead for personalised care and end-of-life care in North East London Cancer Alliance, but this is going to be a double act today with Mary. And really at the time when I was working on the guidance, I was working in the Transforming Cancer Services team in Liz Price's team as the Macmillan Rehabilitation Clinical Lead. And it's a real delight to be here today. The guidance was originally due to be launched back in March, and then of course we had COVID and everything was kind of derailed, so it's just so wonderful to have the opportunity to talk about it today. And the next slide please, Liz. So lots of people to thank, almost too many to mention. I want to give a huge thank you to Macmillan for all the support, both in funding my role within the TCST and also for the then subsequent support of the lymphedema community practice. All members of the community of practice, past and present, and all members of steering groups, working groups, everyone who's given their expertise and their support of this project. I'd like to thank the whole team in TCST, especially Liz for her guidance and her oversight, and the lymphedema community across the UK for all of their wisdom and support in bringing this project to an end. Next slide, please. So I just want to take us back just a little bit to when this work actually originally started, and we're going back to about 2015 and 16. And then we were very aware that there was no national strategy for lymphedema in England, and yet we knew that the economic impact and the impact on the individual with lymphedema was significant. And there's just some figures there that we've used quite a lot when we've been talking about lymphedema, that England spends more than £178 million on admissions, and some work from Macmillan estimating that for every £1 that's spent on lymphedema services, the NHS saves £100 in reduced hospital admissions. Lymphedema had actually been prioritised in the 5-year cancer commissioning strategy for London, and it had been in commissioning intentions for several years. But despite this, we knew that there was significant variation in service provision and also quite significant workforce challenges, with many services small, perhaps not very sustainable, and people working single-handedly. And really, to throw into the mix with all of that, we knew that the prevalence of lymphedema was expected to rise. So there was obviously quite an issue there, and it was fantastic to be given the opportunity to do a really focused piece of work to think about how we could go about reducing variation and increasing provision in lymphedema services across London. Next slide, please. So you'll hear more later from Karen Freight from the LSN and from Emma Tingley from Macmillan talking about the impact of lymphedema, but these are just some quotes here and I think they're quite powerful, just talking about the impact of lymphedema, how frightening it can be, often how other healthcare professionals don't really have much of an idea what to do, and that finding information and support and treatment, good quality treatment, can really make a significant difference to people's quality of life. Next slide, please. So I'm going back now to talk about the original guidance. So we did produce some guidance back a couple of years ago that was then refreshed, and I'm going to talk you through the kind of timelines of this. But back then in about 2016, we wanted to produce some commissioning guidance to really look at what were the issues with lymphedema in London and what needed to be done in order to try and reduce some of that variation. We wanted to find out from our commissioners what would be helpful in a guidance document. So we did some qualitative work, and I interviewed, I think it was about 7 commissioners to really understand if we were going to produce guidance, what would be helpful, what would you like to see in it, what would encourage you to use it, because we didn't want to create something that would just get dusty on the shelf. We pulled a steering committee together and we convened experts from across the country to support us with this, including, lymphedema specialists and service users themselves, commissioners, the third sector. And the exam questions really were, what does good look like? How should it be commissioned? And what do we need to go to raise the profile and the awareness of lymphedema services? Next slide, please. So these were the original resources that were produced back in 2016. That was the original commissioning guidance. And then a year later, the template business case. The reason that we wanted to produce the template business case is really because any excuse. After we produced a lot of recommendations and there's things that we wanted people to do, we wanted to make it as easy for them as possible. So within that original guidance, we had mapping of services and we had clear recommendations, and then the business case was a follow-up. Next slide, please. And this is just talking a little bit about the impact of the original guidance. So we had worked very closely with the Lymphedema Support Network, and as Karen says here, the guidance was an important piece of work in which the patient voice was at the centre, where it rightfully belongs. The work was so important that the National Lymphedema Partnership Group worked up to a guidance document, a national guidance document, and that was launched in Parliament. We also got a publication in the British Journal of Community Nursing, and we were highly commended in the 2018 Healthcare Transformation Awards for our work to reduce variation. Next slide, please. And this is a bit of a case study from a commissioner in North London, and we've talked about this a little bit in our new guidance, which I'm going on to talk about in the next couple of slides. It was really important that we were having a difference on the ground, that we were actually, the guidance when it was being produced was actually impacting and influencing people to do something about the lymphedema services locally. And this was a new commissioner who had a lot to wrap her head around in terms of lymphedema services, and she actually says that our resources and our team were a lifesaver. So I won't go through everything in that, but we were certainly having and starting to have impact on the ground in terms of commissioning. Next slide, please. So I'm going to hand over to Mary now to talk about the lymphedema community of practice.
Thank you, Karen. So this slide really highlights the role of the lymphedema community of practice, and the final bit on that slide, which is about the purpose, is the bit, the message really, that the whole aim of the community of practice is to improve our patients' outcomes. And there's a group slide. Have the next slide. Thank you. So this is our photo of the group. The numbers of participants in the group can vary meeting to meeting. The group is held right-hand side of the slide, which identifies the next. This is the easy slide. Yeah.
Apologies, Mary. I think we've got difficulties. We can't hear you well.
Okay.
Oh, that's better.
Is that better? Am I too far away, perhaps?
That's much better now, yes.
Okay. This slide.
Sorry, Mary, can you please just go back one slide? Sorry to interrupt, because we were really struggling to hear that last slide.
Okay. Thank you, Barbara. This slide highlights a picture, well, this is a picture of the community practice members, and I think it's important to recognise that the group does vary. The number of people at the meetings does vary according to clinical needs, according to whatever is happening in people's workforce. And the numbers or the names of the guidance working group on the right-hand side of the slide are those community practice members who've been involved specific areas of the revised guidance that we're launching today. Can we move on to the next slide? Thank you. So this is a busy slide, but it highlights the aim of the revised guidance and what it's achieved. And the important message here is that the guidance has been informed by the community of practice, because they're able to provide a very clear link between what's happening in clinical practice and what should happen, you know, in terms of the writing of this guidance and the revision of it. And on the right-hand side again of the slide, you can see the different documents that have informed the revision of the guidance, and the link to all of those is available at the bottom of the slide on the right-hand side. Can I have the next slide, please? So this slide highlights one part of the project, which was the mapping of lymphedema services throughout the Pan-London region. And the questions that were being asked here were: who commissioned the service, the treatments that were provided, the staffing that was available, and crucially, whether the service had any admin support to provide some support for that service, and the types of patients that were involved with the service, and whether these were cancer or non-cancer or a mixture of both. Can we move on to the next slide, please? And this summarises the mapping exercise within the different STPs, highlights the number of lymphedema services, the estimated required workforce, and the actual workforce within these services. And the key point to highlight in this slide is that the North West London area was a priority the first time round when we had the original guidance, with a huge deficit in actual staff that were required, and that was based on prevalence of cancer patients and non-cancer patients. But there's actually been a reduction in the workforce available in staffing within that service since then. So that does raise some issues and concerns within that region. And there is a rising prevalence and a decreasing workforce generally in some areas, which means that London has a deficit of approximately 1/3 of the workforce required. Can I move on to the next slide, please? Now, these two case studies are taken from the revised commissioning guidance to illustrate the economic argument that we're putting forward about the importance of lymphedema services. There's not time to go through them in detail, but they are available within the slides. And I'm going to pass back to Karen now to continue the presentation.
Thank you, Mary. So we've literally just lifted this from the document itself, and you'll see when you have a look that there's clear sections that are looking at the mapping, and then we go on at the end to cover some of the recommendations and the key issues and challenges. And I've summarised here some of the key issues in terms of the commissioning of services in London. So we know that service provision is still inadequate in some parts of London, with significant gaps still across STP areas. There have been no improvements in North West London, unfortunately, since we produced our first guidance. And so North West London has been identified as a priority area for the influencing work moving forward. Despite some of our recommendations, it's still been very difficult to secure commissioning on an STP footprint, and that is something that we're still working hard to do. There's a historical lack of funding, with many providers reporting that their contracts don't cover the whole cost of their services, and they don't stay in line with the increasing demands and the increasing complexity of patients. Small services are still vulnerable, we know this, and if staff are absent or are sick or are away, then often these services are really vulnerable. And yet, despite our first service specification in 2016, it's still quite difficult to capture data on activity and outcomes, and that's something that the community of practice is hoping to pick up as they move forward. Next slide, please. These are the recommendations that we've outlined at the end of our document for system leaders and commissioners, and it's really around what I've just said, around trying to think about commissioning lymphedema on a bigger footprint, to ensure that we're joining up our thinking around lymphedema, and that primary and secondary lymphedema is considered within our integrated care systems as part of managing cancer as a long-term condition, and to really think about how we raise the awareness of lymphedema in primary care teams to try to reduce some of that variation. Next slide, please. These are the recommendations for our providers. And I think the key thing really here is that providers, service managers encourage their staff to attend our community of practice and to participate fully, to ensure that service users are central to all key decisions about care, to develop services and plans where necessary with HEE so that we're really joining up the thinking around workforce education and training and succession planning, to embed the lymphedema minimum data set as part of routine clinical practice, and the full data set's available in the guidance, and then for our providers to ensure that the right coding is used. And just coming to the end now, the next slide. These are the next steps. I'm just going to finish with just highlighting the next steps for our community of practice. When they came together quite recently, we started to think about the short-term, medium-term and long-term ambitions, and we've listed them here for you, and they're also in the guidance document. This work is being supported moving forward by NEL Cancer Alliance in terms of funding, working in partnership with TCST and the community of practice to continue to do work, to think about how we continue to raise awareness, raise the profile of lymphedema and help to reduce some of the variation that we're seeing across London. And I think that's everything that we had to say, so I'll hand back over to Jane. Thank you.
Many thanks, Karen and Mary. I've only seen a couple of questions come in so far, so I'm sure the audience have got questions. If you think of anything that you want to ask, please do type it into the meeting chat for us so that we can offer something to our team when they come back to discuss it at the end of the session. I'd like to pass now to Karen Friert. She's the Chief Exec, as we've said before, of Lymphedema Support Network. And I think Karen has a really useful national perspective to add to all of what we've been talking about today. Over to you, Karen. Thank you.
Thank you, Jane. Barbara, could you pop the slides up, please?
It's me, Karen. It's Liz. I'm having a go. And
oh, hi, Liz. Sorry.
It's just being a bit annoying, I have to tell you.
It's a love of technology. So
yeah.
while Liz is just sorting that out for me, so the Lymphedema Support Network, for those of you who don't know, are the national patient support group for people living with lymphedema. We don't differentiate between people who've got lymphedema as a result of cancer and people who've got it as a result of anything else. But obviously, in the work we were doing with this, we particularly were looking at cancer-related lymphedema. Thank you, Liz. Oh, it's gone again. Still coming.
Sorry, everyone.
Don't worry. Don't worry. It's the one over. It's the one to the right of the one that's gone grey on that screen.
All right. So I think what I'm seeing is not what you're all seeing. I think that's we're all having a bit of trouble today with sharing.
We are, aren't
different
we?
people have had different attempts at trying to share screens. Is it?
There we go. It's behind me now. So we just
no
need
idea how I've managed to do this. It's not
very exciting.
So I wonder if it's because it's slow.
Lisa, would you like me to try?
Yeah, go for it, Barbara.
Sure.
Maybe we just take it in turns between presentations.
Yeah, so I am actually still unable to do it.
Right. I'll see if I can do it. I'm having problems too. Apologies, everybody, on this. This is typical, isn't it, of the system at the moment, and trying to get things to show. Let's see.
Jane, I can also try if everyone else is failing.
Yeah, no, it's not helping with mine, I don't think, either. Karen, could you try?
I can try, yes. Are you seeing?
Yeah, we're seeing that so far.
Do you want me to shift the slides forward for you, Karen?
Yes, please. That would be great. Thanks, Karen.
Like
Can you?
Next slide.
Yes. Can you make it full screen? Is that possible? It's still on the kind of little bit at the moment. Well, Karen's having a go at that. So the LSN is part of the National Lymphoedema Partnership. So the partnership is a collaborative of groups who work to support those with lymphedema. It's got loads of people involved, including. There we go. Okay, and it was formed with the express purpose of reducing repetition in work streams. So lots of people were doing an awful lot of work, and some people were doing the same work. So it was that was its express cause when it was first put together. One of the first jobs we decided to do was build on the work that Karen had been doing in the Transforming Cancer Services Team London. And we, as a group, authored commissioning guidance for lymphedema services for adults in the United Kingdom. And that was launched, as Karen said, at a parliamentary reception in March 2019. Next slide, please, Karen. So what did lymphedema care look like at that point? Well, we were asked particularly because the LSN keeps a list of services. The reason we originally kept that list was when people phoned us and said, where's my local service, we would be able to tell them. So we actually built on that by doing a freedom of information request to all the CCGs around England to gather information about what lymphedema services were being commissioned. We augmented this by contacting all the services that were known to us and other group members of the National Lymphoedema Partnership. And what it showed was at that time there was 203 individual services listed. 63 of those provided care for cancer-related lymphedema only, and there were 5 CCGs with no lymphedema services at all, so cancer or otherwise. 18 CCGs only had cancer-related lymphedema provision, and 4 CCGs had services that were at that time reported to be under threat. Can you scroll down the slides a bit, Karen? There we go. Also, an important thing to mention is that at that point, and still at this point, there is no national strategy for lymphedema in England, and no employed lymphedema lead for England, and no NICE guidance on lymphedema management or accepted best practice guidance. Next slide, please, Karen. So this around the other places that we were working with, you can see the situation in Northern Ireland was that they have got a national group called LNNI, and that was launched in 2008, and they had an employed person leading that, still have, although that post is constantly under threat. And they were awarded an annual budget of £500,000 to create and staff the clinical network and its project work. It has continued to meet objectives. As I said, every time there's a round of costing, then it's always a bit of a hold your breath and cross your fingers moment for the team in Northern Ireland. Next slide, please, Karen. In Scotland, there was variation between one health authority and another. On average, there is just under 2 whole-time equivalents within each authority. Most areas offered treatments of all types of lymphedema. However, there were 2 areas with no identified lymphedema services. They continued, the more the services became known, the higher rates of referrals they had, and unfortunately it's still a problem when people leave, when staff leave, there simply weren't the resources to replace them. There is, however, SIGN guidelines. So SIGN, for those of you who don't know, are a kind of Scottish NICE, and they do have guidance for the management of lymphedema, has been written and accepted and actually reviewed, and there's still a little, can we just go back? Sorry, Karen. Yeah, thank you, and scroll down. Thank you very much. However, there is a Scottish Lymphedema Practitioners Network, and there's also a dedicated lymphedema training and research development department within the Faculty of Nursing at the University of Glasgow, and they do some amazing work. And I think that backs up what Karen was saying about needing to do grassroots education, please. So Wales. Wales are a much smaller nation, and they actually have been doing some amazing work and have been able to secure some significant funding to do that work. In 2011, that it had over 70 personnel for a population of 3.1 million, so much higher coverage than we were able to achieve here. The 7 health boards each have a dedicated lymphedema service. There's a national clinical lead, there's standardised referral, and there's also a great deal of both patient information and healthcare professional information. They've done an awful lot of initiatives like wet legs pathways, as have other places. Derby have one of those as well. And there's a paediatric lymphedema service lead as well for Wales. So next slide, please, Karen. So in essence, the overview of the sort of national picture, and I would like to say this is improving, but it really isn't, is that the commissioning of services across the UK is very varied. It's very complex. Many of the commissioners we contacted didn't know. They simply didn't know whether they were commissioning anything, which seems bizarre. Some are commissioned by really strange you wouldn't think there was a link. So some are commissioned by cancer services, which is why there's a problem for non-cancer patients. One is commissioned by a mental health facility. So, you know, they just really are very varied. But there certainly is not a clear picture or a clear path of what is happening at the moment. Many providers feel there's a complete lack of support or understanding about their services among primary care commissioners and the wider healthcare community, despite the increasing demands on their services. And despite some excellent services around the UK, there remains discrimination based on the cause of the condition and where patients live. I've just seen a question pop up saying asking when the sign guidance will be published. It's actually already out there. It's on their website. It's been out there for a while. Next slide, please. There's a lack of education and training of the wider workforce, so it often leads to an inability to discharge stable patients and a lack of care should they do so. There are demonstrable cost-saving opportunities. We've heard about those, but these appear largely unrecognised by commissioners. It really is quite often like banging on a really locked door, and there's a lack of specialist lymphedema practitioners. So even when posts do become free, there's nobody to fill them. And because of the situation in lymphedema, few are choosing to enter into this specialism as the professional prospects are currently limited. Next slide, please, Karen. So the cost of doing it right, the BLS, so the British Lymphology Society, have produced a tariff for commissioning guidance for equitable lymphedema services. It recognises there's variations in how they're commissioned across the UK, provides guidance for specialist practitioners when lobbying for better services, and focuses on equity regardless of cause. That is available on the BLS website. Next slide, please, Karen. And also a very useful tool that's available on there is, next slide, please, Karen, is a service costing calculator tool that provides 2018 prevalence of population in geographical areas, and you can actually put in the data and it will cost a service or cost the best service. It's a really good document. I would recommend you go and have a look. It is challenging because obviously you have to make the decision, do you cost gold standard or do you cost just any service at all? And obviously this is the higher end of that, but the LSN also has prevalence data for all CCGs in England. So if you've just wanted to know what the likely prevalence in your CCG is, then get in contact with us. If you want to try and cost something, then go on to the tariff guide on the BLS website. Next slide, please, Karen. So what do commissioners and providers need to do? What do we think they need to do? Well, we need to think they need to listen to know what it is to live with lymphedema and build services to meet the needs of the people who are living with the condition, not what the commissioners think they need to build. most patients want to get to a place of supported self-management, but they need that support element, and they always will, and this is quite a challenge. So the least they need is a quick way back into services if they get into difficulties. Next slide, please, Karen. So the cost of getting it wrong, these are just some thoughts from some people we've come across. So some of these actually are quite shocking. Somebody took 10 years to get a diagnosis, somebody who was actually wishing they'd had cancer because then they would be able to get help. And although they make a joke of it, someone actually saying they prefer to live with as an amputee than living with lymphedema. It can be that serious. Next slide, please, Karen. Just a couple of here, you know, and we know that GPs and other healthcare professionals don't get a lot of training, but the problem with that for patients is they don't get the information they need. So this one on the right here, it sounds bizarre that this person thought their leg would just get bigger and bigger and explode, but someone had told them what was happening to their body. They didn't know that they wouldn't, and they really were living in fear that their swollen leg would just get bigger and one day it would explode and then they would die. And that was the fear they were living with every single day. And it was a fear that could have easily been abated if they'd been given the right information or sent to the right place to get the information. And just the last slide, this is very wordy slide. Could you scroll it down, Karen, so people can see the bottom? And I'll just give you a few moments to read that. And I think the last sentence there is, it really isn't unreasonable. All that these people need are people who will understand and help them to be able to manage lymphedema, the physical side of it and the emotional side of it. And I agree with this person. It really doesn't seem a lot to ask. Thank you.
Many thanks, Karen. It's really useful, I think, to be reminded about how the patient feels about this. It's central to all of this. So thank you very much indeed. We now move on to our last speaker for the morning, or for the afternoon now, and that's Emma Tingley, who's the Strategic Partnership Manager for London for Macmillan Cancer Support.
Hi, I'm going to try and share my own screen and hopefully that will work. Going to be a bit speedier. Are you able to see that yet or not?
We can.
We can see it, yeah.
Brilliant. I can't see myself, but that's not a bad thing. If I switch that on, that might help. Thank you. So, okay, brilliant. Thank you. I'm working on two screens, so it sometimes goes a bit funny. And also, workmen turned up this morning with a pneumatic drill, starting digging up the road outside the building, and they've gone to lunch, and they're still at lunch. So I'm hoping that they're not going to suddenly spring back into action and drown me out. I might have to shout out the window if so, but hopefully they'll be away from the road for a little bit longer, and you will be able to hear me okay. So thank you for the introduction. I'm, as Jane said at the beginning, a Strategic Partnerships Manager for Macmillan Cancer Support in London. But what does that mean? I suppose it's a role that oversees London and how we invest Macmillan Cancer Support money in London services and in partners, which is quite a big part of the work that we do, but it also comes with a responsibility for how do we share the learning from the services that we've invested in? How do we make sure that we really understand what they've achieved, what they've learned from their successes and from their failures, and how do we share that across London and also across a wider footprint? And I don't know if some people are on the call from somewhere in the northwest, but one of the other privileges of my role is that I get to connect people through the Macmillan network that I have. They hear about the work that's happening in London and they want to put their professionals locally, in touch with some London professionals as well. So I'm hoping that maybe some people from the Northwest have joined today as well, because they were really interested in the work of the community of practice and finding out how that's working in this one in particular. But most importantly, as Macmillan Cancer Support, we're a patient advocacy organisation. So we really are here to represent people living with cancer, and we have a responsibility to challenge and to hold to account those who set the direction for services. I think I've been quite challenged just listening to the other presenters today, and that quote that you finished with, Karen, was really poignant. And it leads quite nicely into, as part of my research, I have to say, I went back and I started with Karen Robb's blog from 2017. And there was this sentence in there that really stuck out to me around, is it conceivable that a healthcare system that devotes its attention to adding years to life without an equal focus on adding life to years is ultimately neglecting an important aspect of patient care? And I think that's a challenge that we all need to kind of hold on to. And I don't know if you thought about the impact that would have, Karen, when you wrote it in 2017, but actually that's still alive now. And one of the other roles I have in London is co-chairing the Pan-London Personalised Care Partnership Board. So we really are looking at, actually what does personalised care mean for people with cancer, and how do we balance and cope with that kind of tension that often exists between the funding and energy that goes into the front end of the pathway, and supporting people to live well with the consequences of the cancer that they've got. And when I came in a couple of years ago, this work was already underway. Karen's role had already been funded, so I had to work hard to get my head around. I don't know if someone's not on mute, because I'm having a bit of background noise, but I don't know. Hopefully that's cleared it up. Thank you. I didn't really know a lot about lymphedema, so I've had to educate myself about it and see. I'm getting feedback. Oh, that's it. Thank you. But I think today has really highlighted the personal impact of the cancer and its consequences, and the guidance and the revised guidance are really clear about how they articulate and illustrate and describe the impact that lymphedema has on a person's life and on their ability to go out and meet people, that the difference it makes to their interactions with friends and family, how it helps people, how it has an impact on their ability to do work or to live life to as full as they can. So kind of this is the backdrop with which I'm thinking about it all today. I'm going to shoot through quite a few of my slides quite quickly, because they've already been covered in the main from some of the previous speakers, and we've heard about the challenges, the shortfalls in workforce, the inequalities in provision of services. And I know in London there are some great services, lymphedema services, that are out there with really highly skilled professionals. But if you can access those services, it might just depend on where you live. And neighbouring boroughs, the difference between a service one person may have who lives on one road, and as I think we see that more in London because it's so compact and densely populated, if you like, that there's a stark contrast when there are differences across boroughs in terms of the provision that people can access. It's not like you have to drive 30 miles up the road to see a difference. Sometimes it's as close as neighbouring roads. So the ambition of the guidance really is to provide commissioners with the evidence of what good services look like, and that best standard of care, how it can make a difference to people, but also what the economic benefits are for the NHS. It feels like a win-win situation. So how do we get that right? And one of the things, actually, in the pre-meeting we just had before this, one of the challenges Jane was put to us about, actually, what has COVID had an impact on this? How do you keep momentum going for something in an ever-changing environment that's very, there's lots of noise? So actually, some of this work, it's so well articulated within the guidance that hopefully we can cut through some of that noise and really focus on the difference it will make to people's lives. But we all have a responsibility in that. The context really excuse me for this, is around the NHS long-term plan. It's really clear what the blueprint for the future of the NHS is. There's a really strong vision and commitment to delivering personalised care, and recognising that improved quality of life is vitally important, and patient experience plays into that as well. And as of, I think it was September or Q4 in NHS terms, Q3, sorry, in NHS terms, the National Cancer Quality of Life measure is coming out as well, or is being rolled out as well. And I know there's been pilot sites in London, but it gives us another way to actually measure what difference having cancer makes to someone's quality of life, and what difference getting the right support makes to somebody's quality of life as well. And Christiana touched on some of these at the very beginning. In fact, I think it's in the next slide, but within the guidance, there is this section around quality of life and the impact that lymphedema can have on people. You know, having to take time off work, having to stop work completely, experiencing these recurrent episodes of cellulitis, you know, all of these they build up to a picture of having a really significant impact on somebody. And we have a responsibility to do something about that. When we get it right, it really does make a difference. Excuse me. So the service in Hackney, which was the one that was quoted in Christiana's presentation at the beginning, is actually when you do get the services right, you can actually make a difference. This 94% decrease in cellulitis episodes, and 82% reduction in lymphedema, and 87% reduction in cellulitis-related hospital admissions. I mean, that data really speaks for itself. And again, Karen mentioned at the beginning around just a £1 spent on a lymphedema service can save the NHS around £100 in reduced hospital admissions. So the guidance itself really supports the personalised care model. It emphasises, you know, how care should be integrated and coordinated. This isn't, you know, we need to see the people as a whole, and that means lots of services working together to do that. And it supports services to be proactive. It boosts the out of hospital care, and it really focuses on shared responsibility across the whole pathway. And Karen mentioned some of the recommendations that were in the guidance for system leaders and commissioners and for providers. There's another section in there which is around recommendations for third sector partners as well, because we have a role to play and we have a responsibility within this too. One of the things Macmillan has done as part of this work is support the community of practice that's been mentioned, and we saw that photograph of a number of the members coming together, and I've had the joy of actually attending one of their meetings and meeting some really highly skilled, highly experienced people. But when you bring people together in a community of practice, it creates value not just for the members but for their organisations as well, and therefore it has an impact and makes a difference on the outcomes of people with lymphedema. But communities of practice are very special places where they give people access to knowledge and expertise. They really are an underpinning enabler for moving things forward. It can build confidence of perhaps single-handed clinicians or lone workers, or, you know, less experienced people who are wanting to specialise in this area. And it can enhance quality of work, and you know, there's opportunities for personal development in there. And it really is a community. I think that's why we funded it, and that's why we felt it so vital. And actually the impact of that community, there is a sustainable future for it, in terms of there's now somebody from the community of practice who is part of the Personalised Cancer Partnership Board. So we'll be maintaining that momentum and that focus through that format as well going forward. There's been loads of achievements of the community of practice today. I think, you know, when we look back of what they've achieved, it's been brilliant. And today just highlights some of those. But, you know, the revision of the guidance they've done, the data sets, the piloting of that work, creation of best practice case studies, and the lymphedema champions. I'm not sure they've been mentioned yet, have they? But there's now lymphedema champions in each of the SDPs. So there is somebody who's named, who's willing to be there as a support for other professionals who want to find out more or who need to know more. And Karen also talked about the future plans for the community of practice in terms of short, medium and long term. So we're really delighted that Macmillan Cancer Support actually played just a really small part in that, in getting that community of practice up and running. the final thing I just wanted to leave you with was around one of the recommendations that was made for third sector partners is perhaps our role in education. I'm a lung cancer support, do a lot of education for professionals, but we're by far, and no means we're just one organisation that does a lot of this. And Gateway C is a tool for people, particularly in primary care, and they've just launched a new module as part of Gateway C on managing physical effects of cancer that the Macmillan Cancer Support team have been involved in as well, and lymphedema is a part of that. So I've just included that slide there as well as a takeaway resource for people. So there is something tangible that you can actually go and access and learn from this as well. So thank you very much.
Many thanks, Emma, for giving us a completely rounded picture now of how the Lymphoedema Commissioning Guidance was produced and by whom. Thank you very much indeed. We now come to the panel discussion. I just ask all our speakers to unmute yourself and also put yourself back on video so that we can see you all. Thank you very much. And I've just got a few questions I've been picking up as we've been going along. One of the first ones that was asked was, who did you ask and engage with to map the services within the commissioning guidance? I think that's probably a question for Mary and Karen.
So I can kick off on that one. Thank you for the question. So first time round, we developed a template, and what we did was it was a bit of a snowball effect in that we knew where some of the services were. And so my job was to go out and to speak to the providers, the clinical leads for those services, asking some key questions about the service, and then trying to find the commissioner for the service and asking similar questions. And then we triangulated that data, and where they made us aware of where different services were, we would then approach them, and so on and so forth. Second time round, we had a template, but because we were now lucky enough to work with the community of practice, we then created a working group. And so each of the clinical people in that patch was then responsible for going out to their patch and bringing the information back, because they had good knowledge of what was happening in and around their area. So they were then able to collate those templates for us. I don't know if you want to add anything to that, Mary?
No, only to say that I think that the data that was acquired was very rich data, because I think it's very rare. I don't think we missed any services, and as each meeting evolved, you know, people knew of other services that we then included. So I think we managed to get very rich data from that exercise.
Anything else anybody else would want to add? Don't think so. Right, next one is quite a concrete one in many ways, but I think it's probably for Christiana and Mary to answer in the first place. For what cellulitis codes have been picked up for treatment funding, as there are so many out there? I know this is an issue, and I think it's something that Karen Friert has also picked up in her work. Who'd like to kick off on that one?
Well, I can say I'm afraid I can't answer that one, because I'm not aware of the coding system as such, but you know, certainly in the clinic an awful lot of cellulitis is picked up, but I don't know if Mary's been involved in looking at the data.
No, not in terms of coding. I mean, I think in our clinical practice, a lot of the cellulitis is managed by the GPs rather than patients who are inpatients, and therefore they're coded by the GP, I would imagine. So I'm not aware of what codes are used.
Yeah. Karen Friert, have you got anything to add to that?
No, not only to say that we did see if we could create a code for, or ask them to create a new code which would make it more simple, and we were told there was already adequate codes for lymphedema and they weren't intending to add any more. So that's one of the challenges, is that it really is dependent upon the clinician doing the coding, what they code things as, but I'm afraid that's a situation that we continue to struggle with.
Yes. I think the next question is something that is for the future for the community of practice, but we've highlighted that we wanted to influence HEE for education for non-cancer specialists. But what are our ideas in relation to advanced clinical practice? And I think that's something that I think Mary and Karen can answer.
Karen, do you want to kick off?
So I can kick off. So this has been identified, and we've had some conversations. I think this is a question that's come in from Kath Malhotra, and we had some conversations quite early on with Liz Price, who did raise this as something that we needed to have a think about. And we've also started to have a little look at where ACP courses are in place for lymphedema practitioners, and we're starting to build up a kind of picture of that with a thought that eventually this might be something that the community of practice might like to think about and to really have a strategic view on. That's kind of where we're at. I don't know, Liz, if you want to say any more because you were involved in the early conversations.
No, nothing more from me really. That's kind of where we are. So we've definitely clocked it as an opportunity and trying to work out how we might take that forward.
Can I just add that I think this is so relevant because of the fact that a lot of practitioners do work in isolation, and also the career pathway for lymphedema services should be more clearly defined. And if we've got education and training opportunities leading to advanced clinical practice, that would tick that box to enable more junior therapists to have a pathway to follow, more professionally.
And if there's anyone out there that can help us with this or has ideas, Kath, yourself or others, then please come back to us and help us think this through.
Thank you, Karen. I think there's also an issue really about the non-specialist workforce, isn't there? Because you're only a very limited number of people who are specialists in this field, and there's an awful lot of people who are dealing with this kind of problem out there and may not have the skill set, and it can end up resulting in somebody having a leg such as Christiana showed us on some of her slides. So there is a big issue that I think the community of practice is very aware of and is wanting to look at in terms of the broader workforce. And I'm sure people out there are finding the same thing. I'm seeing one coming up about how can we work to prevent the development of lymphedema secondary to non-cancer surgery, e.g. knee replacements. The lymphedema is often established before help is sought. So would anybody on the panel like to tackle that one?
Jane, just before we do, I can see that Liz has got a hand up. Maybe that's relevant to the last point.
Liz, do you want to speak? Well, she'd like to speak, however.
There's always one, isn't there? There's always one. In terms of the wider workforce being educated and having a bit more understanding of lymphedema, Karen, Rob, you might remember that you helped us develop some content for primary and community care education that includes lymphedema as well as all sorts of other things around rehab and also psychosocial support and other bits and bobs. So, and there's a plan with that content to work across the region with multiple stakeholders like Macmillan, what's called the training hubs in primary care, to do a bit of that. So it will be quite light touch because that's what you do with primary care workforce, but hopefully to raise the profile of lymphedema and to reduce some of those horrible stories actually that Karen Free and others have shared this morning about how little it's not just GPs but practice nurses and district nurses and other workforce in the community supporting people with long-term conditions, how little they're aware of lymphedema. So it's on the agenda, folks, is all I can promise.
And just on the topic of GPs, Liz, you might remember that the LSN commissioned a British Journal of a BMJ learning module aimed at GPs recognising and identifying lymphedema. We had requests from many of them for a follow-up module on how to manage lymphedema in primary care, and the first draft of that module is now with BMJ Learning, so they're in the process of formatting that. So that will be a free access, and it is aimed at general practitioners, but anyone can actually do it because it's free access. And that we're hoping that will be launched in the spring, and that is very much on how you manage lymphedema in a primary care setting.
Oh, that's awesome, Karen. Can you remind us when that gets?
Yeah, we will do. We'll be shouting it from the rooftops.
That's brilliant. Great.
So Karen, we'll be able to pick up any links on your website?
Yes, there will be links available. As I say, they're just in the process of doing it at the moment. It's really comprehensive. Christiana's been involved in the authorship as well. It's in some ways really comprehensive, but in other ways it's a doing thing. It's about how GPs tell patients about managing their weight and why it's important. It's about compression, and it's about, you know, the challenges of not being able to get Dopplers done in a community setting before nurses can do compression. So it's a doing module rather than a theoretical module.
Thank you. Going back to the work around prevention, because I think prevention is a massive, massive thing these days, isn't it? And that question about preventing the development of lymphedema secondary to non-cancer, how can we work to prevent that happening? Because it seems to me there's an issue about, again, people being aware of what lymphedema is and acting before it becomes an issue, before it becomes established. Would anybody, Christiana, would you want to kick off on that one?
I can start by tackling that one. Well, I think it's a very interesting question, and I just might pick it apart a little bit if that's all right. I don't wish to be cheeky, but I don't think in this situation the knee replacement surgery itself caused the lymphedema. What often happens is that patient had mild or perhaps moderate lymphedema that was not diagnosed before they then went and had their knee replacement surgery, which then unmasked it or made it worse, and perhaps they got an infection. So the key here is to actually get the diagnosis of lymphedema made before they have their knee replacement surgery or some other procedure that, you know, gets attributed to that operation. And this is a challenge, you know, in the situation of a knee replacement procedure. You know, we need to educate the orthopedic consultant, the orthopedic nurse specialist, the GP. There are so many people there that could have made that diagnosis before the operation and, you know, missed the opportunity to prevent a disaster. So we all need to take responsibility and ownership for this at improving education. And, you know, as Karen's saying, we're trying to do that with the GPs, and there are several of us going around giving lectures where we can at GP seminars. We've finally got lymphedema on the medical students' curriculum at St George's, first time ever. We're embarrassed to say, but also proud to say, you know, this should have been done years ago, but it's been a challenge. And I would like to think that gets rolled out at a national level, this sort of almost online education about lymphedema that everyone can access, regardless of whether they're a doctor, nurse, physio, MLD therapist. We need to get this out there.
Absolutely. Thank you for that. Anybody else would like to add any comments to that?
Can I just say, from a patient perspective, we tend not to use the word prevent, purely because we don't know yet why some people get lymphedema and some people don't, and quite often people, particularly post-cancer treatment, we've found if they get lymphedema, they get into this cycle of blaming themselves for having it, because they one time did the gardening without a gardening glove, or they decided that they wanted a sauna, and I think it can put blame where blame shouldn't be. So we tend not to use ever the word prevention. We tend to say reducing the risk. So just a shout out for the patient voice there.
Yeah,
I absolutely agree, Karen. I think the word prevent should be avoided. Yeah, it's a wrong message.
There's a very interesting comment, and I think you'll all agree with this, and that's Katrina's one about early intervention.
Yeah, absolutely.
You've got to get in there fast, and we all know from the data that doesn't always happen, and that's one of the things this commissioning guidance aims to do, is to try and get early intervention into the set of everybody. We've got another quite specific one, which is around guidance for GPs on accessing and measuring for compression stockings. So they want guidance about this.
We had huge discussions when we were writing the next module as to, did we actually want GPs to be prescribing compression? And it's really difficult, because in an ideal world, then everybody with any level of lymphedema would have access to a lymphedema service, but that really isn't the reality. So there are actually most of the compression garment manufacturers already have guidance on how to measure for their garments. There's also online on YouTube, there's already some guidance, and in the new BMJ module there will be a video showing how to measure for a simple low compression butt compression below knee garment. But I think the reality is I struggle to imagine a GP will be actually doing this. I think, you know, I can't really imagine a GP sitting on the floor with a tape measure and a rolled up trouser leg. But, you know, I think probably it's more likely to be a practice nurse role, or, you know, with the groups of GPs that are getting the practices that are getting together with the primary care networks, perhaps it might be an opportunity for them to employ a physio or somebody with a special interest to be doing that work.
Interesting. Another question really is, how did you, what are the nuts and bolts of bringing a community of practice together, and what are some of the issues that you found when trying to develop the community of practice? And really this goes to, well, all of you actually, because Emma was involved with this as well. What were the issues? Karen, are you going to kick off? Karen Robb.
Happy to kick off. So really good question, and there's been other communities of practice that have been at various stages in development in London that have come to me and have asked me, you know, what were the challenges and how did you go about doing it? I think when you're bringing together, whether they're clinicians or not, a bunch of busy people to talk to you kind of, you know, work together and network for something that they feel passionately about, there's still going to be challenges in terms of time and resource. And I think one of the things that we identified early on is that we did need to have facilitation, and so getting some funding just to get things kicking off seemed really quite important. And, you know, really grateful to Macmillan for giving us that support so that we could have that facilitation, and just to support with the kind of day-to-day bits, like, you know, getting people to think about things ahead of the meeting, you know, doing work in between meetings, having somewhere to meet. You know, back in the days when we actually used to meet face to face, that seems a long time ago, doesn't it? You know, thinking about the venues, you know, providing some lunch or getting people to bring their own lunch and letting them know, you know, all these kind of like administrative things. So that seemed quite important. And that's not to say that you'll forever need that facilitation, because I think as the community of practice grows and matures, then roles will naturally adopt. And I think it's important to think about, you know, who your committee is going to be, who's going to take the lead and all of that sort of stuff. So that's just some kind of thoughts from me, and I'm sure others might have some things they want to say as well.
Mary?
Yeah.
I think one of the problems that I saw quite early on was the fluidity of the group. Certainly, we're very good at the opportunities for professional development. The community of practice is a very good. Sorry, can you hear me? Yeah.
If you come nearer, yeah.
Yeah, sorry. It's an opportunity for professional development. Actually, there was a job to be done as well. We were coming together to support each other, but we were also coming together with projects to complete. And that does need a certain number of people who are there every time to be able to achieve the aim of it. So I think that was a little bit frustrating to start with, was that each meeting perhaps there were more people joining, but they were a little bit fluid, and that was, you know, you know,
we've lost you a bit, Mary.
Sorry, can you hear me now? Don't know why that's so bad. Sorry. You know, obviously the group was going to be a bit fluid because we all have a day job. We all have things that we are responsible for clinically. But in order to get everything achieved, we did need people to be able to commit to coming to the meeting. And that for some I know was a problem.
Emma?
I was only going to add to that and just say, I think you always have to recognise with any sort of community of practice that it will go through stages, and, you know, it will evolve, it will develop, it will move on, and that's okay. Sometimes, you know, as somebody who really wants to get one going, you feel a lot of pressure for it to be successful right from the beginning, but these things do take time. And like you say, that fluidity of membership and the external pressures that people have got, you know, you come together because you're really passionate about a shared vision and a shared goal, but life gets in the way. And I think you need to just be kind to yourself and not expect instant success, and to roll with it.
I think from my perspective, one of the interesting things is I think using online facilities, and we've all got better at it, despite what's happened today on the webinar, we are much better at using these things. We can have meetings that are shorter, get some work done, see each other over at the end of the day or over a lunch session, which is what proved to be the most popular timing for our meetings. And we're going to be going forward in that kind of frame for now, at least. Obviously, face-to-face really does help, but being able to do it online is not impossible. If anybody wants to start a new community of practice out there, you just need to be passionate about it. And as Mary and Karen alluded to, people do change within that group and have different responsibilities at different times. You just need a golden thread running through it of people who are prepared to commit to pushing it forward and to doing some of the hard work that's involved if you think you're going to do some projects. And that has been interesting for me, being involved with this group of people who are highly passionate and have done some fantastic stuff. But it is hard work keeping going with the day job and with COVID lockdowns, dare I say it, interfering as we go along. But I think we can rise above that. I think we can manage this. It's possible.
Yeah, the other thing to say is you don't have to be an expert to be part of a community of practice, because that's absolutely one of the benefits of going along. Even if you feel completely out of your depth, you'll just find yourself surrounded by people with so many different skills and expertise there. It's just such a great learning experience. I mean, my background was in speech and language therapy, and I was part of a community of practice probably 15 years ago. And actually, I'm still on an email group for it, and it's still going in some shape or form. And it's really, I've learned so much from those people that I was with, and we've all developed, and new people have come and moved around. Some of the stuff that Liz is putting in the sidebar, there's some really great literature on communities of practice.
Absolutely, yeah. And on top of that, I think you get a lot out of it. It's those kind of conversations that I used to remember. I'm going to show my age now. This is when you went to get your coffee or went to the photocopying machine in the NHS for something, and it was those off-the-cuff comments that meant you thought differently about something or got you thinking about something. And I think that's what the community of practice seems to do when I see people in practice coming together in this particular one. And it is a range of people from the very experienced to the much less experienced, or people just starting up in new roles because they are very isolated roles in lymphedema. And so that's been interesting too. So hopefully we've encouraged other people across the country to perhaps have a bash at this. It is worth attempting to get this going. Right, any other questions coming through? Anything else I'm picking up? One of the other issues that we've talked about in the past is we've got this guidance, it's fantastic. We don't want it to gather dust on a shelf. That would be such a travesty. What I'd be interested to know is, how do we help the person who's working in lymphedema use this document to enable their commissioner to see how this would be a really worthwhile thing to commission? What do they have to do? Has anybody tried it? Taking it along to the commissioners or setting up meetings, etc., etc. I'd like to hear from our team if anybody's had success, how they achieved it with the guidance. Anybody willing to take that one up?
There's a great case study actually within the guidance of how it's been used. I think Karen flashed it up, but it's so worth going in and having a look and reading, because I mean, that case study, I mean, it stands out to me because it really talks about how the guidance helps them to really understand what is lymphedema, what difference does it, it's, I can't, as a commissioner, I can't be a specialist in absolutely everything, but this tells me what I need to know, and it's really supported somebody to do that. And I think to have that illustrated within that document right at the beginning is really important, and just to me just demonstrates how it can be used, and to have it in there is just fantastic.
Yeah, and I think also something that I think commissioners are challenged with is that some of the NHS unfortunately still kind of has pots of money that are allocated to various things. So sometimes some of the cases we make, so for instance, a reduction in spending on cellulitis, actually that might not be something they're spending money on anyway. So, you know, I think it's very important to talk to your commissioner. Commissioners are real people too. And I think actually say to them, you know, what is it? What would make a difference? What are your levers? What's important for you? Because if we can do the work we want to achieve whilst also helping them to achieve something that they want to achieve, then it's a win-win for everybody. And the patient gets the most benefit out of that. But you know, we've seen situations, literally situations, where somebody has had a leg injury. District nurses have been going in 3 times a day. The person's been sitting there with their foot in a bucket because they've got so much leakage from this leg injury related to lymphedema. And inside of 2 or 3 weeks of specialist lymphedema intervention, that leg has dried up. There's healing going on. That person's able to get back out in the community. The community nurses and the community nursing auxiliaries are not having to go in 3 times a day. The patient's house doesn't smell because of all the liquid they're using. You know, all of those things might be a lever for a commissioner. So talk to your commissioners, find out actually what it is that they're trying to achieve and try and dovetail into that.
Karen, Rob.
Jane, we've got some commissioners on the call, and I just thought this would be a fantastic time to bring them into the conversation. So I know we've got Wayne and we've got River, and if they wanted to unmute themselves, it would be wonderful to hear from them, wouldn't it?
It would.
Yeah.
So yeah, I'm happy to talk because I think it's a fair point, but I also think actually, like Karen has said, commissioners are individuals as well, and we all want the same thing. The outcome for me is about the benefits it poses to the patient, and that we can fund it, because the bottom line is that no matter what we like, what we want to do, we have to find resource to provide it. So that's the key. The part for me is that we're fortunate in WELL CCG in London that we have a really good provider actually that provides across North East London community wound management and lymphedema services. But you know, the challenge for me is about how well is it connected back to our cancer services itself, and how does that pathway really sit? I think that's a fair challenge for me to kind of look at. And like I said in the chat, I'm fortunate enough that Karen, you sit in the Allliance in North East London, so we work quite closely together. So I'm fortunate enough to be able to kind of try and tap on your knowledge at points as well to make sure we really do get the right service out there. I think it's obvious that when the presentation from Christina was given around some of the legs and the real difficulties that patients have, it's a no-brainer that we'd want to try and improve that. But how that's done, I think that's what this commissioning guidance will help us with. Because I'm not a clinician, we don't have a direct clinical lead for something like this. We do have a cancer lead that it might sit under. We do have community provision or long-term condition leads, but we won't have something for lymphedema specifically. So it's really helpful to have the commissioning guidance that's available.
Thank you. Can I just ask you one question? Do you have links across other networks of commissioners? I see we've got some other commissioners willing to speak.
So yeah, we all I say we all work together. I think certainly in North East London. So I know my counterpart who's on the call, River, relatively well, and we do look to where we can join up and learn from each other. I think the difficulty sometimes is that your services and our approaches and our pathways and our clinicians don't always marry up in terms of the same approach, but for something like this, I think there's a potential for us to work together, and that's what we try to do where we can.
Yeah, that's brilliant. Thank you very much indeed. I've got another commissioner come in. I'm sorry, I can't see your name because it's gone underneath my chat bar.
Is that me?
Yes, it is. Sorry, can you introduce yourself?
I'm River Calverley from the city in Hackney, and so yeah, to echo sort of Wayne's words, it's I mean, we're lucky we have Accelerate. They've been in City in Hackney for many years now. The service has you know, grown. We do hosiery through that, so GPs actually have to order the hosiery anymore. So it's something that GPs are very proud of, that they've got rid of all those PIN codes. They were apparently having to prescribing codes that they had to look through. So they're very grateful that Accelerate managed that all for them now. And obviously they've done a great job in City and Hackney with very low rates of cellulitis and lymphedema coming up now. So it does work. I think the problem for commissioners generally is matching up what is actually in the hospitals and what they're actually paying for with understanding that the link and that they can take it out. But it's finding that activity and in order that they can invest in lymphedema services. I think that we were in a good position several years ago where we could invest to save in the future, and we had money surplus. But that's not the same for all the CCGs, so they have to think about how a proper business case that makes sense, and the data is always difficult with those business cases.
Thank you very much indeed. Well, we're running out of time very, very rapidly. So thank you to all the panel for speaking and answering those questions as they've come in. I'd just like to hand over to Liz Price now, just to close the webinar.
Thanks, Jane, and thank you to everyone on the panel as well. Lots of great comments in the chat, lots of great dialogue just now as well. So I know people have to go, but I do like to try and close these things properly. So if you can hang on for a couple of minutes, please do, but understand if you can't. So I think just to really try and bring together, we've seen some pretty nasty images that were shared at the beginning. We've heard some really upsetting stories from patients, and ones that I've been around this stuff for a while. I'm not a clinician, but every time I see these images and every time I hear someone's story, it really gets me. And I feel a bit emotional now still, like after 6 years, this still happens. And I just kind of think, if we don't do something now, then when? You know, for £1, we're saving £100. There's an economic case. There's a really clear quality of life case for people. I mean, how awful would it be to live the way some people have to live, when after 6 weeks of treatment, you can make a huge difference. The bits that we touched on around workforce, you know, we're in a worse position in some parts of London than we were in 2016 when this was mapped, and actually we're hundreds of practitioners short in terms of caseload. The workforce through COVID has really suffered. Most of these wonderful ladies and gents are single-handers, so trying to cope during COVID when you're a single-hander, never mind at any other time of your career in the NHS. So we've absolutely got to act, and we've got to make this a priority. And, you know, commissioners, I know you have a tough job with all the other things that have to be done. And this isn't one of the things that has to be done according to NHS England nationally. But I really hope that today, the work that Karen Robb has done when she was part of my team, the community of practice and all the hours that have gone in to refresh the guidance, keeping the community of practice going forward. I really hope that that shows that this is something that we can do in addition to the other things that we have to do, and that actually it's something that we're all motivated to do something about. There's lots to be done around lymphedema, but it all feels manageable if we're committed to doing it together. So please do think about how to do that within your ICS STP Alliance footprints, and how you link in with your colleagues who aren't necessarily cancer specific folk, because for lymphedema it needs to span both cancer and non-cancer worlds. So thank you again to the people who have presented today. Thank you to Jane for facilitating, to the community of practice, to Karen. We didn't get to have a proper farewell for you and other colleagues in TCST, but I'm so proud of the work that you have done in lymphedema and also in cancer rehab, and I'm also really proud that you're still my colleague, albeit in another part of London. So I'm glad we're still working together on this and keeping it going. If you don't follow Karen on Twitter, please do, because she is amazing. She is an international expert, recently published. So please do follow her on Twitter. And lastly, with everything that's going on outside now, please stay safe and stay well and look after yourselves as best you can. It's going to be tough, and it's probably going to be tougher than the last time round. So if we don't look after ourselves and after each other, it's not going to be a very pleasant winter at all. So let's do what we can. Thanks everybody. Thanks for staying on in your time.